Good morning, everybody. Thank you for being online today this morning in order to participate together at this breast cancer webinar. I would like also to thank to the organizational team for inviting me to give this talk. My talk today will be about a clinical case, a case of postmenopausal breast cancer woman whose onset of the disease were with unusual unilateral orbital metastasis as a unique symptom. My name is CRISTINA OPREAN. I'm senior medical oncologist in Timișoara, Romania at the Oncohelp hospital, and also I am a PhD student at the University of Medicine and Pharmacy, Timișoara. At the beginning, I would like to show you my place of work. This is the Oncohelp hospital in Timișoara in the west part of Romania. This is a quite new hospital, founded 15 years ago. It belongs to the Oncohelp non-governmental organization that I co-founded 15 years ago. We have in this hospital a clinical oncology, inpatient unit, outpatient unit, a palliative care unit, radiotherapy, and also hematology. And this is a winter picture of our university and medicine and pharmacy, Timișoara, that I graduated around 20 years before. I published this case that I will present today last year in May together with some colleagues of mine from the multidisciplinary team and together with the residents in medical oncology. We published this case in journal Diagnostics. For me it's important this publication because I'm involved in my PhD thesis about I study about postmenopausal breast cancer patient, and I published some interesting casing and challenging casing on this patient. So one of these cases I will present you today. So we know from the literature that 6% of the women with breast cancer have metastasis at the onset of the disease. Between 2 and 5% of diagnosed cancer patients will develop orbital metastasis. Breast cancer is responsible for the most of orbital metastasis. Around 30–60% of all causes or cases are caused by breast cancer, followed by prostate cancer and lung cancer. We know that we have two main different subtypes of the invasive breast carcinoma, lobular carcinoma and ductal carcinoma. And we also know that lobular carcinoma has higher likelihood to metastasize in unusual sites like gastrointestinal, genitourinary system, peritoneum, pleura, bone marrow, central nervous system, leptomeninges, and also orbit. On the other hand, the ductal carcinoma often gives metastasis to the classical site, lung, liver, bone, and brain. The majority of the patients with orbital metastasis have a history of breast cancer, but 20% of the cases, orbital metastases are the first manifestation of the disease, as it was in our case that I will present today. Differentiation between orbital metastasis and the primary orbital tumor is difficult in absence of a known breast cancer diagnosis. This is the reason why we need a tissue biopsy, at least a tissue biopsy, but if it's possible, we would like to have a surgical excision of this orbital metastasis in order to have a pathology report. So we present today a 57 years old woman diagnosed with unilateral retroocular metastasis as the first and only symptom of a mammary tubulolobular carcinoma. This subtype, tubulolobular carcinoma, is very rare and very challenging subtype from the pathology of the breast cancer. Our patient had 57 years old at the moment of diagnosis. We're Caucasian woman with no family history of breast and gynecological cancer. She had never used hormonal contraception, and she had some comorbidities, diabetes mellitus type 2, arterial hypertension, mixed cardiomyopathy. The onset of the disease was in March 2015 with diplopia, diminished visual acuity, orbital tenderless mild exophthalmia of the left eye, ptosis of the left eyelid, and all with insidiously onset. Patient was sent to the ophthalmology and to the neurology specialist, and their examination revealed that patient had a reduced visual acuity with a reduced mobility of the eye, with hypoesthesia of the left hemiface and paresis of the third, fourth, and fifth cranial nerve. So both specialists recommended that the patient should had a brain CT and a brain MRI. In April 2015, a patient had both examination. On the left side we have the brain CT, on the right side the brain MRI, and it is obvious that we have on the left retroocular intraorbital region a tumor that is infiltrating ocular muscles and left optic nerve. Is better seen in the MRI on the right side, but is also could be seen on the left on the brain CT. So patient was sent to the neurosurgery department in order to try to have a surgical excision of the tumor from the orbital, but unfortunately this surgical excision couldn't be performed, and patient received just an incisional biopsy in order to have a pathological report, and the pathological report show us that is a metastasis of invasive ductal breast cancer. Immunohistochemistry was negative for cytokeratin 20, synaptophysin, and carcinoembryogenic antigen, and positive for cytokeratin 7 and estrogen receptor. The patient was referred then to the oncology department, for our oncology department, for the management of this orbital metastasis with primary breast cancer. At that time, she had a normal weight in COG performance status 0. So clinical examination of the breast revealed a palpable mass of 2.2 centimeters on the left upper quadrant of the breast and the enlargement of the left axillary lymph nodes. On the other breast, on the right breast, we observed a small tumor, 1.5 centimeter, with a clinical characteristic of the benign tumor. So on the left breast, we had a clinical staging of CT2-CN1. Subsequently, patient did a mammography and then ultrasound, the breast ultrasound, and she had a value of CA15-3, almost double compared with the normal value. So we have on the left side the left breast, on the right side the right breast, both in mediolateral oblique incidence, and we see on the left breast that we have a tumor in upper outer quadrant, a tumor and multiple microcalcification in the breast and lymph node in the left axilla. And on the right side, we have just a small tumor with oval shape and with image that characterize a benign tumor. So the BRADS code was 5 for the left breast and 2 for the right breast. So very suspicion for malignancy in the left breast. The patient was sent to the surgery department in July 2015. She received a breast conserving surgery on the left breast, and we have here the pathological findings. So the pathology exam showed us that is a grade 2 invasive carcinoma, tubulolobular subtype, with lymphovascular invasion, perineural invasion, and positive margin. And 10 out of 10 lymph node examined were positive. And we have TNM stage, a pathological TNM staging a little bit higher than the clinical staging. So we had PT2, PN3A according to 7 TNM classification. So immunohistochemistry showed us that is a luminal bed tumor with estrogen receptor positive, progesterone receptor negative, HER2 negative, and Ki67 9%. We have here some image from the pathology examination from the pathology department. All this image was obtained by courtesy of Professor Alice Dema, the chief of morphopathology department at our University of Medicine and Pharmacy, Timișoara, and she's also leading my PhD thesis. So on the left side, we have invasive lobular carcinoma with isolated tumor cells and single phi arrangement. On the right side, some invasive tumor cells have single ring cell morphology. In this slide, we have the immunohistochemistry regarding the receptors. On the left side, the high expression of the estrogen receptor. On the right side, we have absence of the progesterone receptor. And the last picture from the pathology is Ki67, low proliferative activity. So we had the Ki67 9%. Patient received a kind of adjuvant treatment in September 2015. So post-surgery, we performed a total body CT scan that detected no other metastasis, distal metastasis. So the residual left orbital mass was irradiated with 50 gray, and also the breast, the chest wall, the left axillary lymph node, and the left supraclavicular lymph node were irradiated. And as a systemic treatment, patient received hormonotherapy with anastrozole 1 mg per day once daily. After that, patient was followed up according to the 2015 ESMO guideline recommendation. After almost 4 years of disease-free interval, and patient having no symptoms with the exception of unilateral blindness due to irradiation, we discover a huge value of the CA15-3, more than 4,000 units per milliliter, whilst the rest of the blood tests were normal. We proceed to make mammography and CT scan for discover where is the problem, where is the relapse, and we discover that the relapse on the CT scan, the relapse were in the bone, in the peritoneum, and with ascites, and on the retroocular region, left retroocular region. So we consider at that time that it could be considered a visceral crisis. So we try to give the patient chemotherapy, monotherapy, in a palliative chemotherapy with paclitaxel every 3 weeks, and also we gave the patient ibadronic acid every 3 weeks for bone metastasis. The chemotherapy was barely tolerated by the patient with several adverse reactions, grade 2 emesis, grade 4 febrile neutropenia, and grade 3 peripheral neuropathy. So we try to manage as best as we can these side effects with a symptomatic treatment according to the guidelines. After the 6th cycle of chemotherapy, the general condition of the patient gradually declined. She had the deterioration of echo performance status to 3, so she developed a complication like occlusive syndrome and increase of ascites. So patient was transferred to the palliative care department, where despite of the best supportive care, the evolution was unfavorable, and she died on December 2019. So I have here some discussion mainly regarding to the pathology. Pathology result in our case from the primary breast tumor was discordant with the orbital metastasis, revealing a less common subtype of breast cancer named tubulolobular carcinoma. According to the WHO classification from 2012, this tubulolobular carcinoma is a distinct subtype of breast carcinoma with overlapping morphologic features of invasive ductal carcinoma and invasive lobular carcinoma. Some authors consider it is a subtype of invasive ductal carcinoma based on positivity for ecadherin, while others claim that it is a variant of invasive lobular carcinoma. In our case, the contingent with lobular morphology and the small ducts from the breast resection specimen was negative for the ecadherin. So this is the reason why we consider that we have here a tubulolobular carcinoma rather than the mixed ductal and invasive carcinoma, in which the ductal component had to have a positive ecadherin. So in conclusion, our case reported a retroocular metastasis as a unique symptom on the onset of the breast cancer. This is the first case reported of orbital region metastasis of a tubulolobular carcinoma. We worked as a multidisciplinary team, and we took care of the patient as best as we can. So we are proud to announce that the survival of our patient was 56 months. That is superior than the survival reported in literature, that is between 22 and 31 months. Our patient had a disease-free survival of 4 years, almost 4 years, with hormonal therapy, and unfortunately the disease recurrence was chemorefractory with taxane-based chemotherapy, as we expected in a lobular carcinoma. I would like to thank you for your attention, and also would like to thank all the team, all the colleagues that was involved in this case and in this presentation, in the paper that we published last year. On the first row is my resident in medical oncology, and on the second row we have here the colleagues from the multidisciplinary team, from the pathology, from the radiology, and from the surgery. Thank you very much for your attention, and goodbye.